And it's just a huge honor to bring back my buddy Dale Miles, who lives up the street in Fountain Hills, Arizona. Thank you so much. You were on episode 16, so when we started this show, you were like the first person I contacted, and you finally signed up on episode 16. And I wanted to bring you back 1,000 shows later because your field changes so rapidly. Let me read your bio.
Sure.
Dr. Dale Miles is adjunct professor of oral and maxillofacial radiology with the University of Texas in San Antonio. He was chair of the Department of Oral Health Sciences at the University of Kentucky, the graduate program director of diagnostic sciences at Indiana University, and has held positions at the University of Connecticut and Dalhousie University and the Arizona School of Dentistry and Oral Health. He is a diplomat of the American Board of Oral and Maxillofacial Radiology and the American Board of Oral Medicine. Dr. Miles has been selected as one of the top clinicians in CE for the past 12 years by Dentistry Today. He has authored over 135 scientific articles, 6 radiology textbooks, and the best-selling atlas on cone beam images, Atlas of Cone Beam Imaging for Dental Applications. He has a website for teaching the dental team about digital imaging at learndigital.net and cone beam imaging at drconebeam.com. Dr. Miles has a full-time practice in oral and maxillofacial radiology in Fountain Hills, Arizona. To date, he has read over 23,000 cone beam scans. And at first today, I thought it was going to be a bad day because when I woke up to look out the window, I showed you that picture. It was a scorpion, 2 inches long. And but the good news is that you were the next person I saw. So I went from a scorpion to Dale Miles. So Dale, what's really changed since episode 16, which was, believe it or not, 3 years ago?
I can believe it was 3 years ago. A whole bunch of things have changed in the industry. First of all, as I sort of predicted, most cone beam manufacturers went to a variable size field of view. Early on in the day, there used to be small fields of view and large fields of view, and not a whole bunch in between. Now, most machine manufacturers actually have devices that can vary the size of the field of view, so they're much more. They have much more application in the practice of dentistry. Software's improved. Service. There's some companies that do good service. There's some companies that, like to sell and then, don't provide the service afterwards. I'm not going to mention any names.
Oh, come on. It's Dentistry Uncensored.
I know.
It's Dentistry Uncensored.
They censor themselves, actually. The word goes through the industry, so.
Well, it used to be small fields because the endodontist really wanted to find that extra canal in a molar, all the way to the large fields where the orthodontists want to do it. Mm-hmm. So on these variable things, when they switch to small field, is it really good enough for an endodontist?
Good question. I don't think it ever really was, and that's my opinion, because the smaller the field of view, what happens is they change the exposure factors, and it introduces noise into the system. So I get small fields of view from endodontists that, even though there's some detail that's a little bit better in it, there's enough noise that it's a trade-off, okay? So most of the machines now are dental alveolar, so 8x8 or 9x13.
And what unit is that, 8x8?
Sorry?
What unit is that?
Oh, that's
inches?
centimeters.
Centimeters?
Yeah.
8x8 centimeters, yeah. And the other one's 9x...
And 9x13, and again, they vary. If you go to the websites for the different manufacturers, they'll show you all the different sizes that they're capable of doing. And when you ask me about the endodontists, a lot of the endodontists ended up abandoning the small field of view because, as you and I know, as dentists, we would get a patient or send a patient to an endodontist that needed a root canal in the lower left and one in the upper right. Well, if you have a tiny field of view, you have to take 2 volumes. So they saw more applicability in having a slightly larger field of view. So the popular sizes are probably the 8x8 centimeter and up. And the image quality is quite good in all of them. There are a couple manufacturers that still don't have the information, and if you're out there listening, one of the things I did early on is I told a company called Plan Mecca that I did some consulting for, that they needed to add filtration before the detector. In other words, they needed to get out the low energy X-rays that capture soft tissue, because the soft tissue would come out in the scan, and it was hard to get rid of, so their image quality was poor. So I said, you need to put copper filtration, on your machine, and they did. They retrofitted all their early machines. There's still manufacturers that I think could clean up their images. Vatek being one, maybe even Carestream. Trying to think if there's one other that I get in all my clients the original Soronas. They were terrible. The Galileos, the new machines are quite good, okay, but they still get a lot of soft tissue capture, and you need to get rid of that in order to have the higher bone detail for the things we do in dentistry.
I got a theory about Plan Mecca.
Yeah.
When you go up to Scandinavia and you visit Plan Mecca in Helsinki, Finland, and 3Shape in Copenhagen, Denmark, it is so far north. In the winter, it's virtually unlivable for like 9 months. And so the only way to cope is you either work 12 hours a day, 7 days a week.
Or invent something.
Or you drink.
Oh, that's true too.
And so you go in those companies and their employees, I mean, they're in this lit building with all these people, and for 10 months, man, nobody works harder. Mm-hmm. And I had the same theory when I went to Creighton, is that when I got my MBA at ASU, it was great weather. Everybody's going to skateboarding and wearing shorts, and everybody's partying. But I went to college in Creighton,
right?
And so many times on a Friday or Saturday, we'd look out the window and it just like sleet, snow, drizzle. We're like, well, might as well just stay in and study, because you couldn't go outside. Sure. And I thought to myself at ASU, if I would have been to ASU undergrad, I probably would have flunked out. There's so many things to do. This is Dentistry Uncensored, so I want to start with just the controversial, the ugly, the gross. There's a lot of people that think this is a lot more radiation. And that these kids, they get a stomach pain and they're 6 years old and they take them to the emergency room, they do a CAT scan of their stomach, and then they go to the orthodontist for ortho, they're doing a CAT scan of their head, and that a lot of kids by 21, they've already had 6 CAT scans, mm-hmm. and that this is not good, this is too much radiation. What do you say to all that?
Well, it's not just me, it's the entire medical and dental profession. They're basically endorsing a campaign. I'm going to talk a little bit about Image Gently. The dose from cone beam is very low. If I had to give you some numbers, typical machines, and it varies because of the size of field of view and the exposure factors and other things in the machine itself, anywhere from 12 to 15 microsieverts to 100. And you don't have to worry about the units, just listen to the next numbers, okay? A medical CT of the head and neck is about 2,100 microsieverts. So we're way down in the low end.
We're 15 to what?
15 to 20 for some machines, up to maybe 100 to 120 for others. And anything in between, depending on all those exposure factors. Now here's the deal though. With medical it has improved, and there are occasions, childhood tumor, brain tumor, you need CT and MR information, so there's no way around that. But this Image Gently campaign, which is a public campaign, has been endorsed. I think I sent you a link to look at, endorsed by the ADA, the ADHA, every dental professional specialty, okay, and now the FDI and others. And it's really a campaign to reduce CT dose to children. However, when dentistry got involved, what they did is they resurrected a number of things that we've been teaching people all these years in schools that they still don't do. So I'm going to do a Karl Rove thing on you here. I know you didn't anticipate this, but I'm going to whiteboard.
Karl Rove?
You know Karl Rove? Former... Anyway, he was...
Send me Karl Rove. What is he, a former what?
Oh, if you obviously watch liberal TV and you don't watch Fox News, okay? Karl Rove is basically a guy that worked in the Reagan administration, who was the architect of the contract with America kind of thing. And he always brings these clipboards out, these whiteboards, because they ask him political questions on who's doing how well in what state.
Just want to say imagegently.org.
Yep.
And on Twitter, they're at Image Gently, and I always retweet. A lot of times when you're following me on Twitter, you're wondering, well, why is Howard tweeting this company or that company or whatever? Is that an advertising? I've never been paid a penny. I don't sell my retweets. It's just so I know you're driving to work right now, and so you can go back when you're listening to podcasts And so I just retweeted that. But anyway.
Okay, so what I was trying to get at.
Oh, Karl Rove, yeah, that guy.
Yeah, that guy. So you can put his picture.
Good looking, bold, handsome man.
So the two things that I sent you that were talking points today were the collimation of the dental X-ray beam and the use of cone beam only when necessary. So this is where we are on this particular list. But these are the 6 things that all the organizations in dentistry have now agreed to. And you can pledge to this online. You can go to imagegently.org and pledge to do these things. And so my pledge, because I don't have a practice anymore, I read cone beam scans, was to actually go ahead and help disseminate this knowledge or this information. So I'm going to go through the list really quickly, and I know I'm going to hog the speech pattern here for just a second.
No, take all your time, buddy.
Number 1 is to select your X-rays. Okay, what does that mean? Well, that was selection criteria. That means examine the patient first to determine the need for the X-ray and then go ahead and prescribe it. Take it. Don't just have the staff member start with a full mouth series on a patient that you already saw a year ago. Use the fastest receptors possible, and that's, unfortunately, in North America, we're still at around 30 to 35% of dentists are using film. That's nowhere else in the world except third world.
Say that again?
About 30 to 35% of dentists are still using X-ray film. When
25 to 30?
35%, which means about 65 to 70% adoption of digital. Okay.
So 1/3 film and 2/3 digital?
Unfortunately, if I go to Canada...
And why is that unfortunate?
Because digital is much better, okay, and much lower dose. And you can do things with it. And it doesn't have any chemical processing. I mean, you go to the Learn Digital site and you'll see why digital's better. I've been doing that since 1989, The next thing is with the collimation of the beam. Now, we taught people this in dental school. We actually learned rectangular collimation on the tube, on the X-ray tube. I brought one to your office about 3 years ago. It was the little device that you can attach. Green lights come up, called the True.
I still have the picture.
True Image. So do I. I brought it on a drive for Ryan. But nobody does this, and the reason they don't is because they think that their dental assistant or hygienist can't actually hit the image receptor with anything but a big round cone, and that's not true. You can reduce 60% of the exposure, the skin surface exposure, for every image that you take to a patient just by using rectangular collimation. That's a huge dose reduction. And again, dental doses are low, but they're still factor into everything. One of the things that's interesting, I dug this out for a grant proposal years ago. 2011, dentists took 750 million bite wing X-rays.
2007?
No, 11.
2011 in USA?
In the USA.
In USA took how many?
They took 750 million, we'll say dental X-rays, okay? You know that number now has got to be over 1 billion, right? Well, think about this. How many retakes happen in an office? The numbers that I could ferret out were 10 to 13% retakes, the ones we know about. That means there's 100 million unnecessary dental X-rays taken every year in the United States. Well, by collimating and using the device that we showed you that has the magnet, okay, that links the receptor to the tube head, you reduce retakes tremendously. It's hard to get a retake when the receptor's linked physically, to the tube head. Anyway, so that's and there's other devices online that in that Image Gently campaign. If you go through the dental professional part, they'll show you. Child size, the exposure time. I don't know about in your office, but I've been in offices where the last exposure is the same as the previous because the next one is the same as the previous because they forget to change the actual exposure factors. So it's pay more attention to kids when they're in your chair, and reduce the exposure time because they don't need the same amount of time as an adult. You and I with our thick heads, okay? Then we get to the cone beam only when necessary, and thyroid collars are given. We all do thyroid collars on kids.
What percent don't use thyroid collars?
I don't know, but nobody should not use a thyroid collar.
But go back to your chart.
Yeah.
Go ahead. Number 5, use cone beam only when necessary. Mm-hmm. So what are your thoughts of endodontists who, when the assistant seats the patient, it's standard of care to get a cone beam of that molar, and orthodontists, before he even sees the patient, when they do the workup,
sure,
it's a cone beam on 100% of all patients. I mean, you see that, you know it's out there.
Yeah, and you know, not every patient's the same, and not every protocol or procedure is the same. Let's take the endodontist first, okay? I have no problem with endodontists doing cone beam on every case. Why? You and I send them the difficult cases, okay? Endodontists have failures. Why? Because they get our difficult cases, right? So what happens is they need more imaging data at the front end in order to have a successful retreat or to actually treat the patient that has an odd-shaped canal or multiple canals. So I don't have a problem with that because most endodontic procedures are done on adults, correct? Mm-hmm. Okay, well, adult thyroid is very stable. I mean, it's not like a child's thyroid that's developing. So for endodontists, I'm in the camp that says, yeah, if you get the information that makes you a better dentist and helps you with a better clinical decision and treatment endodontically, I'm absolutely for it. So that's my opinion, okay? On the orthodontic side, it's kind of an interesting scenario because the doses are so low. If you totaled up cephalometric panoramic full mouth series in order to do an orthodontic assessment along with your models and visual exam, probably that dose is going to be higher than a typical cone beam dose, not than a medical CT. I mean, there were lots of, in the implant industry, lots of people said, oh, I use, you know, medical CT to get my implant measurements. And it's like, well, you don't need to now, you know. That should be verboten now. Nobody should be sending, you know, people to a hospital to get conventional CT with high dose just to do an implant, you know, measurement. Cone beam, that's a perfect example for that. But back to the ortho. Some schools, based on the information that came out, and you remember the article, it was a New York Times article, okay, a guy named Walt Bogdanich, who wrote an article and said...
Can you find that, Ryan? What is the article? New York Times.
Yeah. It's Walt Bogdanich. He was one of the two authors of the article. Can you spell
Bogdanich?
Bogdanich, I think, Bogdanich. Or it might even be Bogdanovich. You'll have to look it up. But anyway, it came out in the New York Times and it said that orthodontists are frying kids. You know, basically they're taking all these ICATs, and that was the machine at the time that a lot of the data came from. And it was a large field of view, and you could kick the KV and MA up really high. The native capture in an ICAT, the KV was 120, okay, which is, you know, higher than all dental procedures for sure. But the MA, which is more important, was way up at 24 or 48 MA. Well, that's medical grade. That's why their images look so good. It takes X-ray photons to make images, okay? You could dial it back, though. If you had a child in there and you were doing the assessment orthodontically, you could dial it back to 12 MA, which is, again, right in the range of all these other machines, so that dentists would now have to learn, okay, when do I use high KV, high MA technique versus lower KV, low MA technique? And dentists don't want that. Dentists, you know, in your office, this is my office, we want to keep it simple, you know, push the button, make it happen. Can't do that anymore. You really have to think about who's in the chair. If you put Winona Ryder in a chair to take a cone beam and you put, you know, some big, you know, linebacker from the Arizona Cardinals, they're not going to come out the same, just at the same exposure factors. So, and because it's not just a single image, it's a set of data, and you're gathering a lot more information by a CT-like mode, you got to think more about planning your X-ray study, you know, your radiographic study. So.
Ryan, somebody Winona Ryder. I've heard the name. Who the hell's Winona Ryder?
He needs to get out more, doesn't he?
Is she a country music singer?
No, she's an actress.
Winona Ryder.
Black Swan. I'm trying to think of some of the other.
I'm going to go completely off subject because I have the most.
Can I stick to the cone beam for just a
second?
Absolutely.
Okay. All right. Feel free to always tell me to shut the hell up.
No, I will not do that. One of the things that I think is very timely is that dentists get these machines, and the first thing they do is, these images are great. And the second thing is, what am I looking at?
Right.
Okay, because they don't know what they're looking at. So what I did is, myself and a partner of mine who's still in academia, we developed a software, and it was for reporting what was in your scan. It's called Easy Writer, and writer spelled R-I-T-E-R. Okay?
Wasn't that a movie?
No, that was Easy Rider. Okay, and if you
why didn't you go with Easy Rider?
Because it's a trademark, and if you type that in your browser,
send me Easy Rider.
If you type that in your browser, you're going to go to places you don't want to go. Okay. So
which is why England dropped oral cancer and went to mouth cancer.
Oh, really?
Because if you put oral in Google, you're never going to find anything with dentistry. And seriously, that's why they did that.
That's why.
And they think the United States should start calling it mouth cancer.
Well, they've always tried to tell us what they think we should do.
Good one.
All right. I'm a radiologist. When I dictate something, a report, it's templated. I look at anatomic areas in your head and neck scan, the same ones every time. Paranasal sinuses, nasal cavity, airway, okay, temporomandibular joint, cervical spine and osseous, dental, and other. The other is for the things that dentists didn't anticipate that could come back to bite them. Okay?
Like carotid artery calcification.
And others, yeah. And by the way, just as an aside, there aren't just calcifications in the neck, and they're not just diffuse sclerotic plaques in the intimal layers. The biggest population of people that get calcifications in their arteries are diabetics. And the diabetics get them in the medial layer, the muscular layer. When their kidneys shut down and all that small vasculature goes to pot, they can't get the demand. So they get amputated limbs, they get, foot ulcers, they get real problems. They get problems in their periodontium because the small vasculature is compromised. Well, I see more plaques, and they're circumferential, they're around the artery. When you look at them, when you see them in the cone beam, sometimes you have to do a little image processing to tweak it out. And they go up and down the arterial wall. And it's not inside the layer where they're throwing all the lipids, spares and all those things at people. It's actually in the medial layer, and you can't get at that layer. So those people are going to lose limbs down the road, right? So I see all kinds of that stuff in the cone beam scans. So we'll back the truck up. So in those anatomic areas, I say the same things all the time. My statements in the reports are very comparable because I see the same things all the time, except for with the recommendations and stuff in the spine. We see stuff in the spinal column. So when you're in, let's take a simple example, airway. Okay, lots of interest in airway and sleep. So they're looking at the airway, they see calcifications, and they're bilateral, and there's lots of them. They go, what are those? Those aren't plaques. Well, when you go in the menu tab and you get down, you'll see hyperlinks. One of the words in there is tonsillolith. They click on that, a picture comes up, right from my database, okay, a description of what it is, why it's important, and the citation of where I found it. So it helps your decision process, and it helps you make a good document with the things in it that you see that you didn't recognize. You learn as you go. So the software we're really excited about, called Easy Rider, you can buy it standalone, and you can get it through Dentrix, okay, their connected program. We have it, and we're now in that program. And the company that helped make it for me, Cybermed, out of Tustin, California, and Seoul, Korea, they actually have it as a module in their cone beam software. They have a third-party standard, the one I use to read my cases with, all my reports. So it's available in 3 different kind of
So they go to
formats.
Easy Writer, and it's actually
R-I-T-E-R.
R-I-T-E-R.
Right.
So why did you not put a W?
Because that was also taken.
Okay, Easy Rider.
Yeah.
So think of Easy Rider, the movie, then go to Easy Rider, the word, then go to the mnemonic device. It's everything. So Easy Rider, R-I-T-E-R. And this simple program was developed by a radiologist and a pathologist to help clinicians generate simple, precise, descriptive reports for their records, their patients, and their referrals. Buy now. How much is it?
I think it's sold for either $4.95 or $5.95. 2 copies, one for where you work on your workstation with your machine, and one for a laptop, because you and I know we all take work home. So
you had to buy 2 copies?
Nope, just one.
For $4.95 USD. Can they pay $4.95 in Canadian if they're up north since their dollar's sinking? No. Oh, come on. You're not going to give the Canadians a break?
I think it ended up being $6.30 or something like that, because I've seen a couple orders from up there. Actually, I go to the University of Toronto once a year to teach a small field of view cone beam course. It's 30 hours, okay? And I think that should be done by every manufacturer, and if you're listening out there, I think that's what needs to be done. I do a 2.5-day program for Toronto every year because the dentists in Ontario can't even buy a machine until they've had 30 hours of university-based CE. Then they get a certificate from the Royal College that allows them to buy the machine. Now think of that if we had to do that in the US. You know, you have to have all this education before you could even be allowed to buy the machine. I don't think it would go over very well. But there's 4 states looking at it. You ready for this? Michigan, Wisconsin, California, and Washington.
Michigan, Wisconsin, California, and
Washington.
State of Washington?
State of Washington.
Now, California, I believe, because they'll do anything Canada does. They're very high regulation.
Yep.
But why Michigan, Wisconsin, and State of Washington?
I think they're all looking at that model. Michigan, I mean, that's where Blue Cross Delta Dental came out of, right, into Ontario. I mean, we all fought that in Ontario.
That's where Blue Cross Blue Shield...
When the entry point into the Canadian market was, you know, the big Delta Dental in Michigan.
Oh, really?
Yeah, that was way back when I was practicing dentistry in the late 70s.
God, Delta started in 1948.
Unbelievable.
And this is 2018.
Yeah.
Now, you've had algebra, so 8 minus 8 would be 0. 4 from 11 would be 70 years old.
Yeah.
Gosh, dang, that's amazing. Did you ever see the movie Easy Rider?
Oh,
with
I did.
Dennis
yeah.
Hopper.
Yeah.
So you mentioned sleep medicine. Again, on that, do you think cone beam is standard of care for sleep medicine?
You know, I never use the term standard of care because I do a lot of expert witness stuff, you know, mostly related to...
How come you can't get one lawyer to agree on definition of standard of care?
We have an adversarial law system, and that's what you know, you want to have a good defense if you've done something that's been negligent. First of all, we shouldn't do anything that's been negligent, but if that happened, or if the patient and or someone claimed that happened, you want the best, you know, legal.
Back to that standard of care. I mean, you're always hearing that. Like, okay, we'll go to the more...
No, I'll stay with sleep, okay?
Okay, stay with sleep, but then do implants.
I think it will become standard of care, but what do you mean by standard of care? Some docs think that they can treat a obstructive sleep apnea patient just by going to a weekend course. Can't do that, okay? I don't know how many devices are out there now, probably 50 plus, and everybody wants to sell it to you. So of course, you go to these courses and you're not learning anything but what they want you to know about how to use this appliance. It goes far beyond that. If you join any of the national organizations, they have mastership programs, just like an AGD type mastership program, where they have clinical psychologists, they have other professionals that all look at sleep, ENT, you know, otolaryngologists. So here's the deal. Cone beam is a brilliant way to look at all components of the airway. Unfortunately, we all want stand-up or sit-down machines, and the best way to determine, you know, where the airway space is compromised is in a supine machine. Well, they don't sell them anymore because that doesn't fit our paradigm. It doesn't mean it's not good to get cone beam for airway analysis, because they even have programs. Anatomage by Invivo and Cybermed both have a program where you click on points in the airway and it draws you a 3-dimensional volume colored, with the red area being the narrowest, and it gives you the exact measurement. You affect your treatment, you bring them back to take, you know, or put the appliance in, take another cone beam, and you can see if you've opened the airway. So again, dentists think it's only airway. It's not. It's the paranasal sinuses, the nasal cavity, all of that affects your breathing. Okay, there's what's it called, nasal valve collapse. People that have some problems in their nasal cavity can start to take a breath and one ala will just collapse on one side, so they have to get a little implant in there to open it up. So there's a lot to learn about sleep, and cone beam, I think, is the most effective way to look at it. So it will become the standard of care, but I don't think it is currently.
Can I take that to implants?
Implants
and wisdom teeth extraction.
Yeah. I've always said, and you can go back to the Dental Clinics in North America, 2008. I wrote an article. They gave me the leftover chapter. They said, we want you to write a chapter on the future of dental maxillofacial imaging. Like, I'm supposed to predict the future, okay? So what I did was I took statements manufacturers made and questions that came to me in lectures. And I said, okay, someone said, will cone beam imaging replace panoramic, for instance? Because you can reconstruct a pan from cone beam, right? Cone beam data. And I went, absolutely not. Why? Well, I haven't seen a reconstructed pan in 23,000, well, they're not all large scans, but I haven't seen one that looks as good as a 2D grayscale dimensional digital pan. Okay, and a digital 5 to 10 microsieverts. So it's a low dose, highly useful image. It'll never go away, okay, in my humble opinion. It won't be replaced by cone beam. The next question was, will cone beam imaging become the standard of care for implant imaging? And I went, absolutely yes. Now, is it now? No. What do you mean by standard of care? Is it the standard locally, standard nationally, standard worldwide? That's what the lawyers will say. They'll say, well, don't you have access to journals, and can't you go to a program to learn about implant imaging? Now you know it's the standard of care. That can be a very successful argument. Like you said, lawyers will argue either side, and they'll do it very effectively. But I don't think you should be doing implant imaging without using cone beam data. It's just better. You can see the thickness. You can see the submandibular salivary gland fossa that you might have dropped into because you thought you had a lot of bone there. You can figure out if you need a sinus lift or pre-surgical surgery. And trust me, you're going to love the title of this talk. I do a talk called The Rocky Horror Implant Show. Okay?
Which is the #1 movie of all time.
There you go. That's why I stole the title.
It's been seen 100 more times than the #2, Gone with the Wind. It was Gone with the Wind.
Yeah, right.
And it's still in 1,000 movie theaters in America right now on Friday and Saturday nights.
Well, the reason that I took that title, I've seen the movie. Obviously, I grew up in that time period, but the number of implants that I see. Let's take just the anterior region, where I'm sure the dentist said, "Well, I can visualize and palpate and drill my drill at the proper angle." The number of implants that I get, because I get them post, right? I don't get them as they're planning the implant. I get, hey, there's a problem here. Can you look at it? There's some sinus problem or whatever. I look at it, and there's that implant sticking out the facial bone, you know, all big fenestration, and has to be replaced because they couldn't eyeball the angle. And then I can show you case after case after case, even in the bicuspid region in the maxilla, you know, because there's little concavities, there's little depressions up in there. The number that I see that have no bone over the tail end of the implant sticking out is scary. And I haven't had I have 13 expert witness cases going right now, okay, in different parts of the country. I haven't seen one where the complaint was they pushed the implant, you know, out my bone, and now I'm having all kinds of problems. We're pretty good at healing, and we can tolerate a lot of things. But I have seen implants in the sinus where they've blamed all kinds of things on the implant being in the sinus. And, you know, dentists have to be careful. I think cone beam imaging should be the standard of care for implants.
Well, I'll tell you what, like in our town, we need to, Ryan, will you find me, what's the name of that rhinologist? He's friends of the endodontist Jason Hale. Do you still remember him?
No, I don't.
It's not Tim Hagen, is it?
Yeah, I think that's it.
Yeah. I lectured with Tim Hagen to the Scottsdale.
Yeah, it is Tim Hagen.
Yeah, he's great.
Can you get him to come on the show?
Oh, yeah, absolutely.
Tim, yeah, good memory. But he talks about how, as a rhinologist, he's not a big fan of sinus lifts. I mean, he sees implants that have been into the sinus or failing endo, and the whole sinus is white with Candida fungus. Talk about that a little bit, because I want you to do this. You know how there's like fat shaming and. Well, I mean, like it's kind of if you get breast cancer, everyone feels sorry for you. Yeah. But if you get lung cancer, like, well, you idiot, you're a smoker. I see it with all kinds of diseases. Mental, you know, if you tell someone I got pancreatic cancer, oh, I feel so sorry for her. Tell someone you're bipolar, man, you're messed up, and then they run, you know. And I think dentists bridge shame people because if you're filing, and look at the words they use. Well, why would you file it on two virgin teeth?
Right.
Like, what do you mean a virgin tooth? Is there a non-virgin tooth? How do you measure a non? I didn't see that on Pornhub. Really. 2 teeth screwing. And when you go to a rhinologist, they're like, dude, you had 2 elephant tusk ivory rocks. to attach your little 3,000-year-old Egyptian bridge to. Why did you drill into my sinus? And here's a, and then they show you cases of these disasters. But if you go to the local study club and you say, yeah, I don't do sinus lifts, I do 3-unit bridges, they're like, dude, you're just gross. So the dentists worship the god of enamel and dentin, and it's all sacred. And the rhinologists worship the sinus. So who's
and
right?
The ostium.
And the ostium. So who's right?
Well, first of all, both professions need to remember, first, do no harm. You know, we were all taught that. Dentists think they sometimes can't do any harm because they don't deal with big problems with the patient. You know, they just deal with their, like you said, the drill and fill components. The sinus isn't a impermeable, bony boundary. I mean, stuff percolates through there all the time, okay? It's a living, breathing space just like anything else. And I think you can successfully do implant procedures by doing a sinus lift and other things if it's done in the right hands. I'll give you an example. I had a second molar fail finally that I had filled, I think, the first time with amalgam in I was 15 years old, okay? I'd had root canal procedure done. I had it repaired a couple times. I never had it crowned. Finally, it fell apart. So I went to an endodontist locally who does not only microscopy, but he also does cone beam on every case.
Which one was that?
It's my good friend, and he's been a co-author with me, Tom McClammy. Clam dog, okay?
Tom McClaggy?
No, McClammy. McClammy. North Scottsdale Endodontics.
Send him over to the show.
I would love to.
You know, endodontists their endo shows is the most. In fact, Ryan, you know that video you put up the other day of the oldest video of a root canal ever done from 1917? That's coming up on like 300,000 views on Facebook.
I love it.
It's crazy.
Yeah.
Yeah. Did you see that video?
Yeah.
It was the oldest root canal video ever found. Ben Johnson, the founder of Thermofill, bought it in a garage sale in Kentucky. But anyway.
So Thomas, back to my extraction and implant. I haven't had the implant yet, but he did my extraction, by the way, under rubber dam, through the microscope. I mean, the most atraumatic extract. This was an upper second molar. We were going to let it heal in. He looked at it. I went, you know, I was needed, as old men do, I needed to go to the restroom. I came back to the chair. He says, dude, because he's an old guy like you and me, but he still is, dude, he says, we need to put, you know, an implant in there. He says, that palatal socket is perfect for it, and he named the implant. So what does he do? He drops in an implant at the time that he does the procedure. And it was like, wow, this is too cool. It's been 6 weeks or 8 weeks now. I'm going to go back for post-op, and I'm going to have an implant in Site 15. And, you know, he does it right. You know, he's an interesting guy, by the way. Cowboy out of Bend, Oregon, practiced for 19 years before he went to endodontic graduate program at BU. So
nice.
He's a fun guy. Still a cowboy.
Well, you know, I trust endodontists more that place implants, because if you have a stay-home wife and 4 kids and your only tool's a hammer, and you need to do 8 molars a day, 1 every hour all day long, and I send you failed root canals, you just retreat. Then when they fail in 6 months, after you took $1,500 for it, they go, well, you know, I did the best I could. And it's like, you know, you're not incentivized to say, no, I think this is fractured and junk and you should pull it out. Yeah. But if you could sit there and say, no, this isn't worth saving, let's pop it out and place an implant, I trust you more. And people say, well, that's really bad. I mean, every PhD economist says incentives matter. And how many hospitals take a CAT scan on every single patient that walks in there because they're going to bill Medicaid and Medicare $6,500, and I trust those guys more. I want to go back to your lawsuit. So you know, Socrates says the only thing that really motivates humans is greed or fear. So if you're not greedy to do the right thing, you're fear of doing the wrong thing. You're in a dozen lawsuits. You've been doing this for a long time. When did you become a specialist in radiology?
Long before it became a specialty. I did my postgrad work in San Antonio in 80 to 83.
And what year was Röntgen?
Röntgen was, he had discovered the X-ray in 1895, November the 8th. And the reason I know that is...
November 8th. November 8th? You know the date?
My oldest son was born on November 8th, and one of my grandmothers, my maternal grandmother, was born in 1895. So it's easy for me to remember.
Wow. And he died of suicide, didn't he?
No, that was Edmund Kells.
Edmund Kells. I thought the story went that Röntgen was always taking X-rays of his hand.
Edmund Kells.
That was Edmund Kells?
Yeah. No, Kells. Edmund Kells. Kells. You can look that up.
He was the one taking X-rays of his hand?
In the United States.
And got hand cancer? Yeah. And the pain was so bad he shot him?
Well, it started with his hand and then went up his arm, and finally they...
Edmund Kells. How did Röntgen die?
I have no idea.
I thought he committed suicide.
No, you've probably been disseminating bad information for years about that.
No, I posted the Wikipedia link.
If it was from suicide, it wasn't from holding X-rays. I don't know how Röntgen died.
Yeah, okay. Ryan, can you search out how did William Röntgen die? He was in Germany?
He was in Germany, but I think he was Austrian by birth.
Austrian?
Yeah.
Well, Austria and Germany, those borders.
Yeah.
Those borders. If you look at the history of Austria and Germany, many times Austria was much bigger than Germany.
Oh, yeah.
I mean, those, Poland.
Yeah.
Poland is the wildest country.
Michener. You need to read Michener's book, Poland. You know how he wrote Centennial and Hawaii and Chesapeake, and read Poland.
It's like documentary fiction.
Yeah. It's a sad story, though. All the people that invaded Poland, it's still going on.
Well, they're in the wrong place. In the United States, people always forget you got an ocean on two sides.
Really. And Canada
north, to the north. That's like living in an apartment and your best friend's up in the loft.
Yep.
And in Mexico, the culture it just so fits. But Poland, God dang, they were the crossroads of Germany and Prussia. And, I mean, they were just in the worst location. And you know who has that worst location now? And people always don't realize it, is China. China is surrounded by Russia, Mongolia, India, Pakistan, Vietnam. I mean, they're almost every country that touches them, if they just made like the German Blitzkrieg, could make it to Beijing.
Yeah, sure.
So, I mean, if the United States traded places with China, they would be 10 times more military paranoid.
I can't see Vietnamese invading China, though.
Well, they got 90 million people, and they beat us.
Yeah, but they're only right there.
but Vietnam beat the United. We lost the Vietnam War. They have 90 million people. If 90 million people, if they made a blitzkrieg attack, they'd probably get damn far.
Well, you're still talking conventional warfare.
Well, that's what they master.
They would be nuked off the face of the planet, and then it would carry on. Anyway, we won't go there.
We won't go there. But I want to go back to the fear, though. Lawsuits. You've been doing lawsuits for a long time. What generally is a dentist doing where he's going to end up with an attorney?
Well,
what usually goes wrong?
Actually, most of the lawsuits that I've been involved with are not... They mostly involve oral maxillofacial surgeons, and one of the big areas right now, which I don't think combing would help actually, and I know that might surprise you, is that it helps in the post-mortem when we're trying to evaluate why did they do what they did. The damage to the lingual nerve, you know where it comes off, and it can be high or low up in the posterior part of the nerve.
You're always afraid of the inferior alveolar nerve, but you always hit the lingual nerve.
Yeah. Well, the lingual nerve damage, because a surgeon and/or a dentist, usually they do straight burr, the bone burr, and they're trying to get a trough to get some, purchase in the posterior part of that third molar region in the lower. They basically perforate through the plate, and the lawyers all claim that's why the patient has the taste problems and altered sensation. And In some cases, I think the patient's being honest. In some cases, I don't think that. I think the lawyers have convinced them that, you know, all of these problems are due to that surgery. So that's one of the areas. Implants in the sinus, I told you, was another one. So, you know, if you're at the front end, if you're entry level and you're at the front end of your learning curve, I would always use cone beam to assess the amount of bone you have and whether you should be going into the sinus with a sinus lift or graft procedure. So the other areas, there aren't many areas. Third molar extraction, the biggest lawsuit settlement, I think in history, was on damage from a third molar extraction from an oral maxillofacial surgeon. And I think it was in Florida, and it was some ungodly fee, like either $2.5 or $3.5 million, and that set the wheels in motion to limit judgments, you know, and penalties against that. So I really do think I know I didn't answer your question directly, but I do think cone beam should be used for all lower third molar extraction. And oh, by the way, when I do 3D color reconstructions of the upper thirds, the ones we all think are easy to take out, the number that I see with nice little hooks on the roots or divergent, you know, apices, you know, the palate going off one way and distal buccal or something going another, making the extraction difficult, is a lot greater than I thought. So I always make 3D reconstructed color views of impacted third molars, no matter if they're maxillary or mandibular, for my clients. They get a picture of it in the report. So.
And I'm going to tell you another thing that gets you in trouble is your ego. You're pulling out a tooth and you snap off a little 2-3 millimeter root tip, and that root tip never, ever, ever causes a problem. You got out 95% of the tooth. The only time that little root tip will ever be a problem is if the body works it out like a splinter and you had to go pick it through. But your ego says, I can't tell the patient I left a 3 millimeter root tip, so I'm going to get out a big 557 surgical board, I'm going to go destroy half the socket, and I'm going to get that thing out, and then you do nerve damage. Do you agree or disagree that a broken off root tip should be let sleeping dogs sleep?
That's a good question. I don't know if I have a really precise answer for that. Probably I wouldn't go digging long for it. If you can see it, if you're in the antral space and you might be able to retrieve it easily, I probably would try it. If you can't see it and you're only trying to open up and get bigger access surgically to see it, no, I probably agree with you. I probably wouldn't do it. I see a lot of a foreign body, which would include a root tip, in the maxillary sinus, because that's where dentists concentrate. There's lots of other sinus spaces in there, of course. But in the maxillary sinus, foreign body is called an antrolith. Well, I've seen lots of antroliths, many of which are root tips. They do cause some localized inflammatory change in some cases. But yeah, you could leave those alone. If there's an AO defect, okay, and it's been long-standing and there's changes in the sinus and lots of mucosal thickening, alteration of the walls, yeah, you got to repair the defect. I mean, those always have to be repaired. So could be at the time of the repair of the defect, you could get the antral space cleaned out and maybe even the root tip along with it. But good question. The reason I went down that path is because your rhinologists, as you call them, the otolaryngologists, when they go into the ostium, remember the maxillary sinus, the dependent portion is where the stuff gathers up. Now you can get inflammatory change around the rest of it, but if you've got inflammatory change and/or fluids in the sinus, they go in through the ostium, okay, with a scope and like a irrigation unit, okay, and they can take out the material. They can do balloon sinuplasty. They can do a lot of things through that ostium. So maybe if a root tip goes into an antral space, maybe we ought to think about referral to the otolaryngologist for clinical and endoscopic evaluation to see if they can go in there and get it out through the ostium.
But you can't, because no one can say that word.
Otolaryngologist or ostium?
I call them rhinologists.
I know you do.
Is that slang?
I don't think anybody uses that term much anymore.
But what's the substitute word? What's the real?
Otolaryngologist. Yeah.
Laryngologist?
Because they all do eye, nose, and throat. ENT. I would just use an ENT doc. Okay. As your term.
Yeah, Röntgen died on 10 February 23 of carcinoma of the intestine.
There you go.
Do you think that was caused by radiation?
No.
And I want to go completely off record because I have access to an amazing mind. There's a lot of dentists. So I'm not talking about, you know, a lot of people sit there and they, who's a big naturalist out there that people think are whack jobs in healthcare? You know, I'm not talking about those guys. I'm talking about really accomplished dentists who don't even like them being exposed to their own Wi-Fi at home. And they are taking out Wi-Fi, and there's people out there now in the news media saying holding the cell phone to the head. And I'm not concerned about anything my iPhone does to my head when I'm talking about. What concerns me is I always keep it in my pocket. My God, I'm worried about what it does to my stones, not my brain.
It's too late for that, Howard.
Do you think holding? I know this is a dumb question, but do you think holding an iPhone to your head all day long and sitting at a desk that has Wi-Fi, do you think that's someday going to come back and bite us?
Or looking at the computer screen, because that's also, I don't know. When you look at pie charts of, you know, we'll call them radiation exposure. Radiation is a spectrum, including the stuff that's from your cell phone and your computer. They always include it as what our annual exposure is. But let me give you, I'm glad you asked me that question. Walking around the planet, we get 3,600 microsieverts of radiation to our body every day. Might be a little worse in Denver because you're mile high and you got cosmic rays and stuff. 55% of that comes from radon in the rocks.
Coming from the ground up.
Yeah. And not only radon in exposure in air, radon in our foods. If you grow plants in soil that have rocks nearby, there may be isotope decay that actually gets into the water supply, that actually gets into your lettuce. So you might be eating organically very well and getting rid of pesticides, but you ain't getting rid of the radon. It's just there. And if it were so bad, and if it were carcinogenic, why did it take a meteor to kill the dinosaurs? Why are we still on the planet with everyone not having cancer? I mean, 55% of our annual dose comes from rocks. When I was in Indiana, I had to have radon, and many of your listeners out there, a lot of states have to have radon testing in their basements, you know, to get the levels down because they've determined a level that they think is unsafe. Well, that's just part of it. I mean, when you look at the cell phones and all the other things, 3,600 microsieverts a year. Back to the conventional CT, remember the conventional CT? At 2,100 microsieverts, you can imagine then why they're concerned about kids, because they get 2/3 of their annual walking around the planet dose from one medical CT. Now, just as much harm can come to a patient from not getting an X-ray procedure. Do you know what I mean? Mm-hmm. If you have something that you need good data to affect the treatment with, you need good data. And if that's a tumor in the brain or a tumor elsewhere in the body, you'll need CT. Lucky for us, we don't see much of that in the head and neck region except soft tissue cancers like oral cancers and all the mucosal things, so that we don't really need radiology for that. Our radiographic procedures are probably the lowest of any profession and probably the safest, but doesn't mean we can't ignore the potential, you know, for some harm.
Well, that dinosaur stuff,
yeah.
My mom is the most intense Catholic I've ever met. My two older sisters went straight into the nunnery after school. And my mom would tell you that from Adam to Abraham was 2,000 years, according to the Hebrew text of Genesis 5,
yes.
And that the earth is only 6,000 years old now.
Yeah, of course. Well,
so you're part of a conspiracy.
Yes, I am.
Well, I want to go back to another thing that's very confusing right here in Arizona. Those holistic dentists. Mm-hmm. Holistic dentists. I mean, they got 8 years of college. They're dentists. They believe that one of the most important things is to go get 10 minutes of sunlight every day for your vitamin D3 to get 30, 40,000 units. And there's a lot of really smart people saying how beneficial that is. And there's a lot of people showing that when you live in like Scandinavia, when you live in Denmark, Copenhagen all winter where 3 Shape is, or Helsinki, Finland where Plan Mecca is, that's really bad. And then, so the holistic dentists, the holistic physicians are saying that. Then they go to their dermatologist. They say, oh my God, right by your toothbrush. After you brush your teeth, you need to put sunscreen everywhere, and you need to not go out in the sun between 11 and 4 p.m. in Arizona, and you need to go hide in the basement. So the consumer really gets mixed information.
Sure.
So how would Dale, the radiologist, how would you opine? Because you live in the desert.
Yes. In actual fact, I had a basal cell carcinoma taken off my left temple about a year and a half after I moved here. But the thing is, they're finding out now, research, it's not just this exposure we're getting now, it's the exposure you had over a lifetime to your skin cells. When you went and laid on the beach, and wherever you laid on the beach as a kid and didn't put sunscreen on, you know, and got burnt to a crisp, and then had to have, you know, all kinds of balms and things to make it feel better, but you went out there again to get that tan, that's still going to come around.
So you think the cancer in your 50s and 60s and 70s is the stuff you did when you were in your 10s and 20s?
Some of it is. Some of it is just it's called immunosenescence, where basically our cells run out of division time. You know, they have there's programmed cell death in our bodies. In other words, from the first divisions to the last divisions, it's already there. So that's why you're seeing genetics and immunology taking over all the cancer treatment and being such a huge part of everybody's disease processes. Your genes are, you know, if they're good, they're good. If they're bad, they're bad. And unfortunately, you can't change that, you know, right from conception.
Oh, you can. You can go to Nordstrom's. And they sell jeans everywhere. The best jeans I have, I bought at Nordstrom's.
Yeah. And, but I mean, that's the whole thing. I mean, I live in the desert. I'm quite happy knowing that I'll be long gone before the cockroaches and the scorpions. They're going to be around a lot longer than we are because they adapted.
Have you ever found a scorpion as big as the one I showed you, the picture
this
morning?
No, and I saw that, and the 2-inchers don't disturb me. It's the little bitty ones that have the venom that's a lot.
All right,
so,
that's
the ones you don't see.
Dale knows his scorpions. It's the small ones again. I've obviously been stung twice. Once I opened up the Sunday paper and it flipped right on my forearm. Yeah. I want to switch to a whole nother subject.
Okay.
Are you okay with time?
Good.
Or do you need to run?
Yeah, you're going to.
Now I'm going to open up a huge can of worms. TMJ.
Yeah.
TMJ. You know, some people think it's psychosomatic. Some people think it's stress. Some people. What are you seeing on cone beam on TMJ? Are you finding?
Well, first of all, you know, you're like every other dentist and patient. I've got TMJ. What do you mean by that? I got 2 of them. You know, I got 2 temporomandibular joints, right? A joint is a joint is a joint. This happens to be a loaded joint, okay? There's, you know, it's not weight bearing like a knee, but it has load on it, okay? And we use it a lot. Look at how we're chatting and drinking and swallowing and whatever. So I see a lot of osteoarthritic changes in the joints, and not rheumatoid. I've seen very few rheumatoid arthritic patients because they go to the rheumatologist and their physician first. But I've seen really, really ugly changes, gross remodeling in temporomandibular joints, condylar head, and the fossa with absolutely no symptomology. I've seen small surface erosions at the front end of the disorder, little remodeling, subchondral cyst formation where the patient is painful. So first of all, there's bone changes. We see those. I mean, cone beam is the best for that. I can make a 3D color image of the I can actually do an AVI video fly around the condylar head in the software that I use. That Cybermed software. By the way, back to Airway, I can do it down your throat too. So when I see lumps in the throat, when I see a mass effect that's closing the airway and I know it's not tonsil or adenoids, I make an AVI video to put in the client's folder. They open it up for the patient, say, we found a mass. That's why you're having difficulty swallowing, and here it is. You need to see your otolaryngologist, okay? Your ENT doc. So back to the TM joint. Not all joint disorders are bone, okay? They're not arthritides or some of the other connective tissue disorders. I mean, I've seen psoriasis up there. I've seen psoriatic TM joint, okay? I've seen patients that have what we call a mixed connective tissue disorder where they have Sjogren's and psoriatic changes. I've seen those kinds of joints, but also we have the soft tissue components. You know, the disc and the elements there, and the inflammatory changes that can occur with trauma without bone change. So the disc problem. By the way, do you know where this? You've heard the hierarchy of disc displacement was the old term. It's now the term's gone right out. Internal derangement was an old term. Disc displacement with or without reduction and/or perforation. You know where that classification came from? Came from three guys: Charles Green, Daniel Laskin, and one other very famous oral maxillofacial surgeon. And when I heard, it might have been Frank Dalwick, when they told me the story, it was, we came up with that with beers around the pool.
Really?
Well, they were into the joint. That's when they were treating joints back then by open surgery and putting in Plaques and all that stuff. And they had to come up with, you know, anterior displacement with reduction, without reduction, with perforation. So they came up with that classification, having beers around the pool. You know, three smart guys. Back to the only way you can look currently at soft tissue in the joint is either by arthroscopy to see if there's a displacement of the disc, and they don't all just go anterior. They can go medial, lateral. You know, the disc can go in a lot of different places. But MR, magnetic resonance imaging, is really the only current way to look and see where the position of the disc is. So if you've ruled out bone changes, if you've got you know, and you've ruled out myofascial pain and the things that go along with, you know, headache and the bruxing, clenching, and you think it's a disc problem, you need to get MR. You need to get magnetic resonance imaging to see the disc. Now, having said that, and I can't tell you much, but one of my oldest, dearest friends who's Italian, living back in Verona now, that used to be the head physicist for Gendex, okay? He's working with a company right now that are working on a soft tissue cone beam machine. So it's going to be able to tweak.
Would it be an MRI?
It's not an MRI. It's cone beam.
But will MRIs ever come to dentistry, or
well,
is that?
They already are in dentistry. You can order. I mean.
But I mean, the MRI is a huge.
It's not going to be in your office.
It's not going to be. They're never going to. Well, you know, they say everything always over the years will go faster, easier, higher quality, lower cost, and miniature.
Yeah.
People always forget the miniature.
Sure.
Do you think an MRI will ever be miniaturized to be in a dental office?
Well, it already is to some extent, but what they do is they do surface coils to do the. So they basically don't put your whole head in the machine, but you still go in the machine, but you have a different size coil so that it only captures your head region. You know, very elegantly, we'll say. Okay, so they do have those units, but you still have to have a magnet to generate. I mean, you know what you're doing, right? You're taking the excess protons that are spinning and you're knocking them over, and then as they return, they give off a little radio frequency. Well, you can't make a small magnet do that. You have to have a big magnet. I mean, these MR machines use the energy of a small office building. You know, just.
Did you see the lawsuit GE just had to pay in India?
No.
They had a GE MRI imaging center, and some employee let someone walk through there, and he had a metal instrument. And
of course.
He was sucked in the machine so fast. I forgot what he had on him. Yeah. But he was sucked into the machine so fast, he broke his neck and died. Ryan, did I ever tell you about my favorite MRI? No. Your little brother, your oldest brother Eric was like 1, and he fell and he hit his head really hard, and we rushed him to Chandler, and the doctor said, I got to get an MRI of this, and but Eric was very upset and everything, and he said the only way we could do it is if you laid in there and held him.
Really?
So I laid down there and got him all comfortable, and got him to nurse my finger, and he was nursing my finger, and we did the MRI, and I was looking at the scope. It was so adorable. But back then, that was 1990, so I didn't get a copy of anything. Are you hurting for time?
No, I'm good.
So this is Dentistry Uncensored. They want to know what machine you'd recommend. I mean, right today is CDA in Anaheim. Dale, how many
I'll be there tomorrow, actually, talking to a couple of manufacturers.
How many machines are there for sale?
Oh, God.
And you know, she's 25. She just got out of school. She's going to open up office. She's got to make this. Just take it off her list. It's like when I talk to an oral surgeon, it's like, you know how many implant systems or at what is
IDS
Cologne, IDS meaning
yeah.
Cologne. There were 175 systems. So my homies just want to say, cut the bullshit. I don't want to evaluate 175 implant systems. Which one do you use?
Yeah.
Which cone beam would you use?
Well, that's a good. I'm glad you phrased it like that, because first of all, I don't do that. Obviously, I read the scan data and make reports, so I don't own a machine. Okay, but I get to see the data from all the different machines, and the question you asked me is just like I get it when I lecture for a day and a half or whatever. I heard what you said about all those machines, but if you had to buy one, which one would it be? I'm not going to do that, because I don't practice like you. You don't practice like Bob or Shirley. You have to sit down, and I'm going to give you a couple things. One I did in the number 16 webinar or podcast that we did. You have to do an assessment in your office, and I actually have a tool on the drconebeam.net site, .com site rather. There is an assessment tool. You can fill out a 2-page questionnaire, which will help us get.
Which website is that? Because you have Learn Digital.
Yeah, and
Dr. Conebeam.
That's it. And
Easy Writer.
I know. No, that's on drconebeam.com. I have.
Is that your main? Could you
for
find
Conebeam? Absolutely. Because
so if you go to Dr. Conebeam, drconebeam.com.
all spelled out. Yeah.
And there's
videos, articles.
But you said there's a
an assessment tool.
And where would that be?
I think it's under. I think the
home
menu is consultation.
Consultation.
Yeah. And
Let Dr. Miles help you with due diligence and decision about which CBCT machine is right for you. After completing this assessment form, you can contact Dr. Miles for an in-office consultation to help you get the best cone beam technology for the application you're considering. So you asked for their name, city, etc. So can I read the questions?
Yeah, sure.
Current products.
Better yet, send everybody there. I don't need the hits, but they can go there and take a look and see.
Well, my goal is that they can make decisions faster, easier, higher quality. That's all I'm trying to do. It's my favorite hobby. I can't. If you'd ask, and you know what's so romantic about this hobby is when I was a little kid in Kansas, growing up at the farms, like when people talk about the internet, they don't know what they're talking about. The internet used to be, when I grew up, those farmers out in the middle of nowhere. They'd go into their barn and they'd have those ham radios, and some of those ham radios were, they could talk 1,000 miles away,
right.
And they would tell the wife, "Well, we're talking about how to grow corn and wheat and silo." They were talking about baseball and movies, and I can still remember being this tall with David Hoff out on the Rockin' R Ranch in Fort Scott, Kansas. We were mesmerized by ham radios. So this is my ham radio.
He just dated himself.
And I'm 32. So which dental distributor supplies your office and supports your current dental technology? Which digital imaging products you currently own? Proposed dental applications, CBCT level of understanding. And by the way, the level of understanding, you might think you understand it. So there's three dentists in my office, right?
Okay, yeah.
Do you know how many times 3 really smart dentists looked at a CBCT and were just like, "What's that?" And we're like, "I have no idea." I mean, it looks like looking at the Galileo images of deep space. I mean,
that's why there's oral maxillofacial radiologists. We know what we're looking at.
Potential impediments to purchase, cost, lack of knowledge. Okay, so this is really good. So if they go there and fill this out and submit it to you, you're going to reply with some answers?
Yeah, most times, and I have to make this is an admission, publicly, that I get very few of those. I'm very bad at answering them, but I do eventually get around to picking up the phone and asking several questions. What I would love to do if it worked out the way I thought it should work out is those people that then in earnest want me to come in and kind of assess the status of their office, I would go there. And I actually had someone from the Phoenix area send me one about a month ago, and that tells you how quickly I've responded, because I haven't responded to him yet. So I owe that doctor an apology. Also, Michael Gelb?
Yes.
Well, Michael Gelb was at a course I did in Suffern, New York about a month ago, and he has sent me filled in part of that assessment tool, and I haven't called him back, and that's almost been the same amount of time. But I get around to it. Sometimes they'll then tweak me with a second follow-up email and say, hey, I sent you this and I haven't heard, and I promise to do a better job on those. But even just filling out the assessment tool by themselves makes them start thinking. It is the first part of their due diligence. And that first podcast that we talked about, I said dentists don't realize how much money they make doing X-ray services. Do you remember that? Mm-hmm. And I said you need to, and what I do is when I call them back, I'll say to them, you need to sit down with your office manager, run a productivity report only for the X-ray services done in your office. And I don't care if you only did one cephalometric in the last year, put all the codes in, the CDT codes, you know, the CPT codes for the procedures, run the numbers, look at it, and then go, oh my God, look at all the money I make off X-rays. And I'm a radiologist. I'm not telling you to take X-rays to make money. It just happens. We need that data to make clinical decisions. When you look at it, and then you look at the number of tasks that you can do in your office where cone beam will help you, then you get a better idea of what kind of machine you need. The manufacturer piece is, I ask them, well, where did you hear about this? And they'll say, or are you working with a distributor? Because you want service after sale. And the only way to get that is to talk to your rep first, look at the products they offer, see if it's a good fit for your practice. So when you asked me the question way back 10 minutes ago, what machine would I recommend? It's practitioner dependent, okay? And that's why the assessment tool. Now, I could sit here, and I might do this. I might put an article. I post little articles periodically. Some of the manufacturers.
Put an article in Dental Town magazine. Well, we go to 125,000 dentists.
I've had two in there for you, but
But the reason I always try to get more is because I know you're a humble guy, but you are considered by all the smartest people I know consider you the world authority #1. And
you heard it here.
No, I know you're a humble guy, but I mean, but really, I don't know anybody who thinks there's someone other than you. I mean, it's kind of like Stanley Malamad with anesthesia,
yeah, of course,
and you with CBCT.
Yep. I appreciate that.
Well, I mean, you know it.
Well, here's the article I think I might do. I think I might send out an assessment tool to all my clients, and of course they're going to give me their feedback based on their ownership of the machine, but I would like to rank them. You know, here's my first tier products, here's my second tier, here's the third tier. Manufacturers won't like that, but you know, it's how we have to sort out the product.
I can't understand. I mean,
I don't work for any of them.
Yeah,
so
I mean, the smart ones. I'll give you a story about the late Bob Ibsen. You remember Bob Ibsen,
yeah,
of DenMat, founder of DenMat? You know, he called me one time and he was so upset because somebody said something on Dental Town and he was all ready to sue me and this and that. I said, Bob, first of all, sue me because it's David and Goliath. I said, nobody could do anything better for my career than have a big old monster DenMat guy worth $100 million sue little old fat Howie because some dentist was sharing what he thought. And I said, so please, you know, in fact, I said, if you sue me, I'm going to go to the judge and I won't even answer questions because I want to be thrown in jail just to get the picture of me behind bars by allowing free speech to dentists.
Sure, I agree.
I said, but Bob, if you had a brain, you do have a private jet because whenever he'd want to have lunch with me, he'd send over a private jet, fly me back to Santa Maria. We'd have lunch at the airport, and then he'd fly me back home. I said, that guy is in San Diego. Send your jet down there, pick him up, fly him back there, and try to understand why he hates your product. Oh, I want to sue. I talked him into it. He flew him down there. It was love at first sight. Two passionate dentists colliding.
Right.
Now they saw eye to eye, and you know, so it's
kind of what
manufacturers.
Kind of what Trump is doing with Kim Jong Un. Oh, never mind. I won't.
But so like dental manufacturers, the smartest dental manufacturers go to Dental Town, where 250,000 dentists have posted 5 million times. Like Sonomed, you do a search on Sonomed. There's 5 pages of threads. Not one person from Sonomed has ever replied to any of that. And I'm just like, but they want to buy ads. in dental magazines. And then there's companies like, other ones where, what's the one out of, Periodent, Prospodent, what Pulp Dent? Is it Pulp Dent?
Okay.
Is it Pulp Dent? Pulp Dent,
I don't know the question yet.
No, I'm trying to remember the name of the company. I can find it. Pulp Dent. And every time someone says something about Pulp Dent, Larry Clark gets in there and explains his point of view, listens to them, and you know how many townies have posted on downtown, Larry, can we come visit your manufacturer? So they'll go down there and Larry will get 4 or 5 townies at a time and spend the whole day telling them why they make the products they do. Sure. Dan Fisher of Ultradent's another one. If you tell Dan Fisher, Dan, I don't agree with anything you say about this product, he's like, wow, tell me why.
More. Yeah.
And so manufacturers should listen to you.
Absolutely. And
say, okay, well, this is 2018. This is version 3.0. But where should version 4.0, 5.0 be? So if you don't like constructive criticism, I mean, I take constructive criticism well. One time some girl called me a short, fat, bald idiot. And you're talking about joint internal derangement. She said I had brain internal derangement. So you got 3 websites. Again, not to confuse them. What's the difference between drconebeam.com, Easy Writer with an R, no W, and Learn Digital? You haven't said anything really about Learn Digital.
Learn Digital was my initial website. I actually started it in 2000. I'd actually been lecturing and, educating our colleagues about digital imaging since 91, and I thought, I'm answering the same questions all the time. I've got to put content. So I started Learn Digital, and that was really to help focus people on the transition from film to solid state detector imaging. And there's still a lot of good content on there, especially because there's still 35% of dentists in the US that don't use digital. And there's panoramic stuff, there's all kinds of things on there. There's dose information, there's links to certain sites. Easy Writer was basically, because we had an arrangement with Cybermed to develop the product, we wanted a standalone version for the doc who didn't want to have, they already bought a machine, they had software they liked with the machine, but they didn't have a good reporting sort of tool. So we developed that reporting and clinical decision-making tool. So that's a separate site. Dr. Conebeam is the one that gets the most traffic right now, of course. That's why I'm sitting here talking to you. Because Dr. Conebeam has articles, my lecture schedule, the decision support, sort of assessment tool. It has videos. I probably have 16 videos on that site. Okay, they're all 2 to 5 minutes long, mostly for dentists, although there's some that are pertinent to patients too. Dentists could download it and show it to a patient about why they're using Conebeam, why they're suggesting that the patient have it. So there's a lot of good content on there. There's at least 30 articles. It also saves me from when I lecture of having to send a handout, because I don't bring a handout. I want people to listen. I want people to really focus on what I'm trying to educate them in, and then to pad out or to fill out the questions that they might have left with. They can go to the website and download the articles from there.
I'm still going to go back because I'm just that kind of a jerk, but do you have a short list of CBCTs that you like? Are there any brands that you trust?
Yeah, there's in full disclosure, for 3 or 4 years I did some consulting for Plan Mecca, so they've always been high on my list. I had them in 5 different dental schools, okay? And the reason I picked that technology was it worked. They're born engineers. Like you said, they 10 months of the year in darkness, so they're all... And
3Shape over in Copenhagen, Denmark, they're walking away with the oral scanning business.
Of course.
And have you been to their headquarters? It's
no,
the same
I have never been there.
Have you been to Helsinki, Finland?
Yes, I have.
But I mean, those are intense cultures. Mm-hmm. I mean, even the dentist. You go at lunch with a dentist and they'll say, well, in the winter I work 7 to 7 Monday through Saturday. And you're like,
yep.
What?
Yep.
because but anyway, Plan Mecca.
Plan Mecca. I still think that the Imaging Sciences iCat is a very good machine, even though and they are the biggest, by the way. They have the most sales anywhere in the world. The reason their image quality is so good is that they basically use higher MA technique to capture. So you need X-ray photons to make an image, all right? What I don't like, and I don't know if they still do this, but all of the manufacturers that basically sold you a maintenance agreement contract with your machine, I have a problem with. I don't know how far to go with this, but I would demand to know what I'm getting for that contract. If I'm paying $6,000 a year on top of the machine cost, what am I going to get for it? Where's my schedule of maintenance? Where's my, when are you going to upgrade my software? The things that they promise haven't been delivered in many cases, okay? It's just, it's like the razor blade. They sell the maintenance contract, but it's a protection thing, and half the time no one gets the value out of it.
Who's the president and CEO of iCat?
Currently, I don't know. I knew the principals that started the company, but I don't know the CEO. It's because Danaher took over.
Oh, Danaher.
Yeah. So
the largest company in dentistry, $19 billion in sales.
Mm-hmm.
I mean, Ivoclar only does $1 billion. The 3M's dental division is like $1 billion. Right. Those boys did $19 billion.
One of the machines that, and I'm having a senior moment here because the two companies, Instrumentarium and Sorodex, reformed the original company called Paladex, and I think basically they are part of that sort of Scandinavian group that makes good machines. But then
so you're saying
Cavo, Danaher, everybody got kind of rolled into one family. Like the Henry Schein, Danaher family of machines, they're all good machines, okay? But
Danaher's not related to Henry Schein. Danaher's out of Washington, D.C.
Yeah, I know.
So they bought iCat?
One has controlling share of the other, though. So
one has controlling share of the other? Mm-hmm. Danaher has controlling share of Schein?
Might be the other way around.
Schein has a controlling share of Danaher on stock?
I don't know if on stock, but in the terms of the decisions made within the company, the decision making still rests primarily with
Schein.
Yeah.
And what does Danaher Schein? What CBCTs do they have in their portfolio?
I'll back up the truck here. The next one I would put on the list would be J. Merida.
Okay, so Plan Mecca, iCat, J. Merida.
Those, to me, those are the top tier. Okay.
Okay, so that the top tier is Plan Mecca, iCat, and J. Merida. Mm-hmm. But what were you saying about Instrumentarium?
Well, now I think I think they're selling it under the Cavo brand, though. Now, what's happened is, with all these roll-ups and other things and acquisitions within the different families of companies, I think the Instrumentarium used to make a cone beam machine, and I want to say it's the OP300 or whatever the designation was. And
Ryan, can you start Google search out the CBCT Instrumentarium OP300? But you think Instrumentarium might have merged with who else?
Cavo.
With Cavo?
I think they're selling it in the U.S. now under the Cavo name. I think
which is owned by Danaher.
CBCT Instrumentarium what?
OP300.
And then as there's other machines coming to the market. For instance, SUNY Imaging. They make the intraoral sensors. They've introduced a cone beam machine. It's made in Japan. I forget who makes it, but I think it'll be a good machine. Panoramic Corporation, the guys that internet marketed a panoramic machine, they are introducing a cone beam machine to the marketplace as well. I didn't mention the Korean company that says they're #1 in the world. They have a good machine as well. It'll come to me in a second. I don't do a lot with those machines. Carestream, I haven't, I used to see a lot of advertising, print advertising, things through your internet almost on a weekly basis from, Carestream about their machine. I'm not seeing as much anymore. And didn't they get sold? Weren't they sold yet again?
Carestream, yeah. I had Soften. I couldn't even. I had it for 30 years. I switched to Open Dental. I couldn't even follow who owned.
Yeah.
I mean,
so but what I want to sort of stress is that all the machines are good. Some are better than others. Okay, I don't think there's a bad machine in the marketplace. There used to be, and that was the original Galileos. I really did not like that machine, and I got into discussions and problems with Serona about that. But that's that happens. I have my opinion about the machines because I see the data. So.
What do you think of their merger and acquisition with Dentsply?
I haven't seen the results of it yet. It's been over a year, right? And what's happening? I mean,
well, a lot of resignations on that merger, yeah. Right? Top
initially,
3 dogs.
Yeah, initially.
So, was there anything I wasn't smart enough to ask?
No, I think you just about sucked my brain dry here this morning,
Seriously, it's always just a huge honor when you do an online CE course or write an article for us. I mean, to have the #1 dog in this space grace our presentation, I'm dead serious. When you're out with dentists and you're lecturing and you're eating lunch and everything, when it comes to anesthesia, they only quote Malamed. Mm-hmm. When it comes to CBCT, they only quote you. And you have the most views and likes on our Dental Town magazine. A lot of back in the day when I started a magazine, editorial was a gut feeling. Well, now we have 250,000 dentists on Dental Town. So when we put up a digital magazine, we know which ones are clicked, which ones aren't clicked. Sure. So, like, if I'm going to build an article on a root canal, well, I've already been publishing articles on root canals. I mean, we started Dental Town the magazine 1994, wow. And the website it was March 17th, 1999 on St. Patrick's Day because I'm 100% Irish. So, so I know who reads who. So there's a lot of people who might think they're all that in a bag of chips, but I'll say actually in your space that the top 3 guys are this guy, and in CBCT it is you, buddy, and it is just a huge honor that you would leave. Where he lives, where all the rich and famous people live in Fountain Hills, sure. And he came down here to Phoenix, where they're poor, and we have scorpions on the wall. And by the way, you're #1 in CBCT. You know what I'm #1 in? Mm-mm. I can do dentistry
with a bottle of water on your head.
No, I can do dentistry underwater.
Oh, cute.
I did that. I took a picture of it and put it on. Yeah, I put it on social media. I have proof.
I think you own social media. Every time I go on Google Plus, I can't. There's nobody else on my page but him.
I think we're so old. We're the only 2 dentists on Google Plus. I think all the millennials are like Google Plus. Didn't they shut that down before Snapchat and Instagram?
Yeah, and then there was Google Chat Room or Google whatever, and a couple of people interviewed me on that, but it was like. It just didn't fly.
Well, Google is, it's amazing how they've let more major businesses slip through their fingers. I mean, God, even when Facebook started, they could have even bought that for a song and a dance. Right. Let me show you my
your underwater picture.
I don't think I can even find it. But anyway, seriously, I know. How long did it take you to drive down here?
About 35 to 40 minutes.
My favorite bike ride. So he lives in Fountain Hills. So whenever you're flying into Phoenix, I'm towards the south, but towards the north, right above the Indian Reservation, there's this massive fountain shooting up there, and that's Fountain Hills. And to leave my house to that fountain is 45 miles. So a lot of times on Sundays we ride up there. My other 90 mile is the NASCAR race field out in Avondale.
Oh, Avondale.
And you leave the south here and go to Avondale. And then my short rides are around South Mountain is 45 miles, or to Maricopa and back. But I quit doing them. I quit doing that ride So I did that for about 3 years. Like every Sunday we do those rides. But every year one of my biking buddies was ran over and killed.
What?
On the bike. And the last one was a guy. He retired. He was 65. I mean, that one was on Pecos right here in Ahwatukee, and it was 9 o'clock in the morning, and a guy was coming back from the Indian Reservation casino.
Of course.
The casino, 9 in the morning, completely shit-faced, ran over him. And when the cops got there, he was playing air guitar on the side of the road. Could you imagine being so drunk? And the guy was still squirming under his car.
Unbelievable.
While he's playing air guitar. And it's like, oh. But anyway, the last time we were going that Fountain Hills ride in a 1 mile area, me and Wendy were almost knocked off our bike twice. And then I realized it's so weird because if I said I'm going to get rid of my car and drive a motorcycle, all my smart dentist friends say, dude, that's dumb. Because it's so dangerous. But if you said I'm going to ride a bicycle, they forget about that and say, oh, well, that's good exercise. But you know what? It's a good way. When I moved here 30 years ago, you could ride your bikes on the streets.
Yeah,
but 30 years later, I mean, losing one person that I have biked with a year for 3 years, I sit there and said, I can't do that anymore.
And it's actually on the website, there's a table that shows equivalent risks of getting cancer from a full mouth series of X-rays.
Which website is that on?
That's on the Learn Digital site, and it says, I think the lead-in is patients worried about X-rays, 1 in a million, and you click on it, and there's a table that comes up. You can
you find it on your website?
Yeah, sure. And the interesting part about that is that. Oh, is this Conebeam, Dr. Conebeam?
No, that's Learn Digital.
Patients worried about dental X-rays, it's 1 in a million. Okay, so there's the chart. You can look on the chart, and you can look.
Can I push this out on social media?
You can, and you can look up the bicycle ride on there because it's going to freak you out.
Well, I just quit doing. I mean, if you're
yeah, but here's the deal. It's not as dangerous as you think, but. These equivalent risks are from insurance morbidity and mortality tables, okay? So a full mouth series of film-based X-rays, your risk of getting cancer is 1 in a million, and everybody freaks out, gets all, well, it's 10 miles on a bike. Wow. Every 10 miles you ride, your risk of dying is the same as a full mouth series of X-rays.
Wow, that's
6 minutes in a canoe, 40 miles in a car, half a bottle of wine, and 1.4 cigarettes. So your risks, that's a great table.
Tell me, I'm Irish. What is wine? We only drink whiskey.
Well, that's cardioprotective along with wine.
Cardioprotective. Again, what an honor to have you come down, Dale. Thank you so much for all that you did for dentistry, for Dental Town, and for oral radiology.
All right. Appreciate it,
buddy.
Thank you.
Thank you.
Okay.
Okay, I missed this video earlier, but a friend came to visit. I don't know if you can see him. He's a black and white snake. I think a smaller king snake. I shouldn't probably be getting too much closer. But you can see him kind of wrapping around the tree, moving slowly, probably looking for some breakfast. It's still early here. There he goes, creeping away. He's about 4 foot, I guess. Black and white markings. Now my neighbor's coming out to leave home. And you can see this snake in the picture, testing out everything that he needs to test out. Probably going to try and cross the road soon. So Howard, this is for you. You had a scorpion on your wall. I didn't want to one-up you, but this is what was crawling through my yard today when I got home from Ahwatukee to Fountain Hills. He's a good guy. He's going to keep the little rats and the rattlers away from my house. Adios, muchacho.
more dental practices these days are using cone beam scanning technology as a diagnostic tool. My guest is Dr. Dale Miles. He is an oral maxillofacial radiologist in Scottsdale, Arizona. Dr. Miles, welcome. Can you talk about what a dentist sees in a cone beam scan?
Scott, they see the things that they're looking for when they actually acquire the scan. They might be taking it for looking at an implant site pre-surgically. They might be taking it for something they've seen in a panoramic image, an extra tooth somewhere, an impacted tooth. But in actual fact, there's a lot more data in the scan, so that they're seeing areas in the airway, in the sinuses, in the cranial vault that they may not recognize or remember from their training. So they're seeing a lot more in these scans than just what they're looking for.
Now, how does the dentist record or document these findings?
Well, typically in a dental office, when they're looking at their images, no matter if they're intraorals, bite wings, panoramics, or now cone beam, they really will systematically look at the image, look for changes, maybe one side to the other, look for dental diseases that are typical, like dental cavities or periodontal disease, gum and bone loss. But now, when they have these cone beam data sets, there's 300 to 500 slices in 3 anatomic planes of section, side to side, which we call sagittal, front to back, which we call coronal, and then axial, top of the head to the bottom of the feet, which is where CAT scan came from, or computed axial tomography. And in those data sets is where they're going to see a lot of information that they may not be used to seeing. For example, we see carotid plaques in the neck, in the airway, and unless you're used to seeing them, you won't recognize them. When they see something that they recognize, of course, they'll chart it. When they see something they do not, they'll have to make a notation in the chart, some type of narrative or dictation or just a written note. So they are obligated to look at all the data in the scan and obligated to record what they see.
Dale, are there any products that help the dentist in documenting these findings?
Well, it's funny you should ask, because a colleague of mine and myself have actually put together cone beam reporting software. We call it Easy Writer, not writer like the movie, but Easy Writer. And it allows the dentist to look at anatomic areas, for instance, the paranasal sinuses, the nasal cavity, the airway, the temporomandibular joint, bone changes maybe in the vertebral column. And by looking at statements and populating the report by checking boxes that correspond to what they see in the scan, they actually can produce very quickly and efficiently a formal report to put in their record, to mail to a colleague as a referral document, or just to store the information so that they know they've looked at the data volume and seen everything in it.
And Dale, going back to what you said earlier, it seems like cone beam scanning is a useful diagnostic tool outside dentistry.
Absolutely. In fact, we not only see those plaques in the patient's neck and the carotid arteries in the neck, because they capture the area of the middle of the head up by the, sort of internal to the condyles, or these joints on the side of their head. They actually will see these same calcifications in what we call the paracellar region, or near the sella turcica, which is a landmark for orthodontists when they do their cephalometric tracings, but general dentists are not used to looking at that area. So there's a correlation often with the patient's systemic health, and it's up to the the dentist to find those changes and make sure that they make the proper referral. In our software, there's a recommendations section. There's only about half a dozen recommendations. For example, if someone sees changes in the maxillary sinuses or sphenoid sinuses, they can click on a statement that says the patient should be referred to their primary care provider or otolaryngologist for clinical and endoscopic evaluation of the paranasal sinuses. So we think we've covered the bases. We make it simple. It's actually an educational tool as well. The more times they look at the cone beam volumes and use the software, the more familiar and comfortable they get with the changes that they will see there that are outside of their normal dental practice.
All right, Dale, thank you again.
Hey, thank you, Scott.
My guest has been Dr. Dale Miles. He is an oral maxillofacial radiologist here in Scottsdale, Arizona. Thanks for watching.